pleasure to introduce Dr. James or Jamie Gaynor. He got his DVM degree at The Ohio State University. He was then actually out in practice, so he was in general practice for a year or so, then went back to The Ohio State where he did his residency in anesthesiology. Essentially double boarded. He's a diplomat of the American College of Veterinary Anesthesia and Analgesia. And he's also a diplomat of the American Academy of Pain Management. He's also a certified veterinary acupuncturist and he's a certified pain practitioner. He's actually also an EMT for humans, which I like it when we travel together because if anything happens, I feel confident that it'll be okay. So, he was at Colorado State for over a decade. I heard somebody in here actually was his pupil. Right there. Yeah, so others may be in the room as well. And when he was there, he was section chief of anesthesiology and associate professor of anesthesia. He currently is, I call you president, but I'm an owner and practitioner at a peak performance veterinary group and has emergency practice and a pain management practice. He's phenomenal, so please, thank you for coming out and join me in welcoming Dr. Gaynor.
You just need to plug in my computer.
Oh, let me take mine out. Yep.
Perfect.
You got an answer?
Perfect. Hey, well, thank you, everybody. I think it's Sunday, right? Sometimes I kind of forget. In fact, this is what I'm supposed to be doing today. I'm a rallycross race driver, and my partner is actually racing today without me. But so that's kind of my Saturday or Sunday thing. But we're here to talk about pain management. So I want to just talk about a couple things before we talk about my stuff. You heard a little bit about some stem cell things. Stem cell therapy is great. Dr. Schaefer talked about 11,000 cases that have been done in dogs. I've done a significant number of those cases. I've been doing stem cell therapy since 2005. So, like later when I'm done with my part, if you have some questions, I'm happy to answer that also. But we're going to talk about acute pain. And like there's some notes here because I had to submit something, but my typical thing is I'm on an airplane, so I start thinking about how I want to change the topic. So these notes are everything I'm going to say, or these notes are part of everything I'm going to say, and then there's some extra stuff. But before we talk about why we treat pain and how we treat pain, I like to spend a little bit of time talking about recognition of pain. Because in the early days of the veterinary profession getting interested in pain management, we spent a lot of time talking about like how do we recognize it? Well, long-term pain, like osteoarthritis pain, really simple. We look at changes in behavior and activity, and it's very simple. For perioperative pain or short-term acute pain, a little more difficult because animals are very good at hiding their behavioral manifestations of pain in the presence of a predator, like pets. Okay? I'm not a predator, I'm an anesthesiologist. I just make it feel good, but no, if you just think about all things we do to puppies or kittens or dogs and cats as they come through the clinic multiple times, like they're getting poked and prodded and things happening to them, and so they really need to, they develop this behavior so they don't actually show what's going on. So as we go through this, we're going to talk about if an animal really looks painful post-operatively, they are really, really, really painful because they can't hide their behavioral manifestations of pain. So I want that ability to hide those behavioral manifestations of pain is really the common denominator for everybody that we treat. And we're just going to look at this video in just a second. But this was really a landmark study out of North Carolina State University that really looked at what really are the behavioral manifestations of pain. And it was really a behavior study. They didn't really use pain. But this was done a while back, and the study was such that there were 3 groups of dogs, all having, looking at ovariohysterectomy. The first group, and this will date the study, the first group received diazepam, ketamine, isoflurane, and had no surgery associated with it, just to look at what was the behavior of patients who were being anesthetized and recovered. The second group was diazepam, ketamine, isoflurane, and no other medication. They had ovariohysterectomy, and then they were looked at with and without human interaction for 24 hours. So you can never do that study today where you just do a surgery and provide no pain control. But really, they were allowed to do that back then because that's really the standard of care. And then the third group was diazepam, ketamine, isoflurane, and oxymorphone. So the results of the study are such that the dogs who got oxymorphone and the dogs who didn't have surgery had very, very similar behaviors, yet the dogs who had surgery without oxymorphone had really kind of different behavior. And they were listless, like without human interaction. And I'm going to try to show this 30, maybe even less than 30 seconds from the ABC News with Peter Jennings. And they followed me around for a day way back when. Did 3-minute national news story on animal pain, which 3 minutes on national news is a really big deal. But I didn't plug in any audio. Do we have a little bit of audio? Or normal, a lot of audio? Oh, we can use the microphone. Perfect. Yeah, good idea. Okay. So here's the clip from the news.
A study at North Carolina State University shows how that instinct works. A hidden camera shows a dog after a spaying operation exhibiting signs of discomfort and listlessness. But when a person enters the room, the dog hides those signs.
Okay, so that's perfect. So the key here is if you're not providing adequate pain control perioperatively, it is hard to tell. And if they look painful, that means they're really, really painful and they can't fake it anymore. The other animals that can't really show their behavioral manifestations of pain are really, really sick animals, so critically ill animals, because they don't really have the energy reserves to show pain. So what that means is for really a lot of our patients, we have to make some assumptions about what is likely to be painful and what isn't likely to be painful, such that we treat them, and if you treat some of them that aren't as painful as you might think, like we're not doing anything to really hurt them. So I'm going to show you another video, and this is a dog which is 1 day post-op TPLO, not at my hospital, but I want everybody, I use this as a training video, and it's a pretty old video, but I want everybody to look at this. I want you to think about how you would score this patient on a scale of 0 to 10, 0 being no pain, and 10 being worst possible pain. Okay, so just some volunteers. What would you score that dog as? And actually, what I'm going to ask you is, if you volunteer, tell me why you think you score in that way. Somebody.
7.
7. Who said 7?
I said 7.
Yes, sir. Why 7?
Well, he's clearly uncomfortable, but he seems to be able to get up and do some basic things like ambulate. He didn't appear to react too painfully with someone manipulating the surgery site. He seems alert and responsive.
Okay.
I heard a couple little whimpers, but no outright crying.
Okay, so there was some whimpering, which we've talked about. He's ambulating, and we'll talk about some of the other things. Somebody else. Another person. How would you score this dog? Yes, in the back.
Well, first I want to know what age he is.
He's a 3-year-old.
So I'd say he's probably an 8 or 9.
8 or 9. Okay, and why?
Because he's a lab and he's whimpering, and they don't do that unless it's really, it's a lab and he's whimpering. And he's using all the energy he can to stay balanced on that slick floor. At least that's how he looks to me.
Alright, so, you know, the concept, so one person says he's whimpering, but it's not a big deal, and she says he's whimpering and he's a lab. So this whimpering thing is an important concept, that we really do have to put that in perspective to the patient, because, like, if this was my current black lab and he was whimpering, I would think, oh, something's really wrong. This was my former black lab where he could whimper if he was hungry, or, you know, he could whimper about anything. This wouldn't mean much. But over the years, I've been scoring this dog kind of as a 7.5, somewhere between 7 and 8. Clearly, he's 24 hours post-TPLO. He's not even toe touching, okay, which makes me think he's painful. I don't know if the vocalization has anything to do with his pain, but really, you know, you need to know a dog's kind of personality. But this actually seems significant to me, that when someone's going to touch his knee, he's really turning around and look at it. And most dogs, when you're just kind of touching them, except for maybe their feet, or they're really sensitive about stuff not used to being touched, like, they usually don't care. So, you know, the whole idea here is just to get you to think about what are some behavioral manifestations of pain that patients can't really fake their way through. Okay? So if it hurts, they're really not going to bear weight on it. And even if they're like faking it very well and you palpate them, they usually don't fake their way through that also. So with that, let's talk about why we're really going to treat pain. So there are 3 principles of pain management that I like to talk about. The first is pain control is good medicine. And what that really means is we don't treat pain necessarily because we're nice people. We're really treating pain because physiologically patients fare much better if they're comfortable rather than if they are uncomfortable. And we will talk about what that physiology is and back that up with some data. The second principle is we need a plan in place for continuous pain control. So when patients have lapses in pain control, that they really developed a greater likelihood of developing maladaptive pain, problem pain, as we'll talk about it. And we need a multimodal approach to pain control. Very few types of pain really are amenable to one single intervention. You know, we do NSAID studies and we do opioid studies, but we really know that, you know, if we're just talking about perioperative surgical pain, an NSAID and an opioid are much more effective than either one of those by themselves. And when we talk about the multimodal approach, it really isn't just drugs. It can be a lot of the other components. So let's talk about the newer terminology, then we'll back up these concepts. So we're used to talking about acute and chronic pain, but acute and chronic pain only talk about a time course rather than what's really going on in the body. So our newer terminologies are adaptive pain and maladaptive pain. And adaptive pain is that pain which serves a biological purpose. It's the signal of impending or actual tissue damage. It's the kind of thing that keeps us from burning off our fingers as little kids when we touch the hot stove. And in our world, it's typically related to surgery, a medical problem, trauma, as those underlying issues resolve, the pain goes away. So the important thing to recognize is that adaptive pain is typically short-term in nature. Long-term would be pretty unusual. Maladaptive pain, on the other hand, is the body gone wrong. It's not processing signals correctly. Patients are painful when they really shouldn't be painful, or their degree of pain is much greater than it should be. And really, we'll talk about how that can be a short-term problem, like minutes, or a long-term problem over months to years. So this is as complicated as we're going to make pain pathways. And we're going to use this to demonstrate two dogs. One is a Labrador Retriever with a fractured femur, another Labrador Retriever with arthritis of the hips. And if we think whether it's a fractured femur or arthritis, that's a peripheral source of a noxious stimulus. And then that noxious stimulus goes through the peripheral nervous system to the dorsal horn of the spinal cord. And this dorsal horn is really important. It's processed at the dorsal horn of the spinal cord, travels up the spinal cord to higher centers of the brain, where then it's perceived as pain, right? Whatever the behavioral manifestation of that may be. At the same time, we may pet this dog, inducing an innocuous stimulus, which goes to the dorsal horn of the spinal cord, travels up the spinal cord, higher centers of the brain, inducing probably a pleasant response. And that's the spinal cord working the way it's supposed to work. So that's what we want to have. However, over a certain time course, depending on what the noxious stimulus is, and the constant bombardment of that noxious stimulus to the dorsal horn of the spinal cord, we can get changes in the dorsal horn, which involve turning on the Nmda, N-methyl D-aspartate receptors, inducing what we call wind-up central neuronal hyperexcitability, some version of maladaptive pain. But the significance of that is once those Nmda receptors are turned on, the spinal cord now amplifies the signal as it goes towards the brain. Hence, we have more red arrows here. And so this higher intensity signal hits the higher centers of the brain, and hence the perception of pain can be worse than what's actually happening out here in the periphery. So just to put a number to it, like the level of pain may be a 4 here and an 8 up here, just because of the spinal cord not working correctly. So the goal is really to protect the dorsal horn of the spinal cord, keep these Nmda receptors turned off. Come back to kind of the time frame here. Once these Nmda receptors are turned on, we may pet this dog, touch this dog, inducing another innocuous stimulus. But now that stimulus can go to the dorsal horn of the spinal cord and actually get converted into a noxious stimulus, such that the dog responds in a painful manner. And that's a very important type of pain called allodynia. Allodynia is a painful response to an innocuous stimulus. And if you're not used to looking for this, probably this coming week, today is Sunday, you go into clinic tomorrow, and for the next 4 or 5 days, you're going to start seeing these patients. Because you're going to examine them, and they're going to seem hypersensitive. You're going to say something about hypersensitivity to an owner, and the owner can almost invariably describe the onset of that hypersensitivity to within weeks or months of either a major trauma or an orthopedic procedure. So I also think that a lot of the fear biters that we identify in our practice actually have underlying pathophysiology related to pain. They are fear biters because they are afraid that you are going to hurt them, because if you touch them, it truly hurts. So we've certainly treated a number of these dogs. Really, perfect example is a dog that came to me, and we knew the dog's history really well, so this worked really, really well. This is a dog, big, 125, 130 pound Mastiff, who went to a different practice for TPLO surgery. There was some discussion post-TPLO that the dog woke up vicious. right? Well, the dog truly did end up being vicious after this, and went back for 30, 60, 90-day rechecks. No one could touch the dog. The owners thought, well, maybe it's still painful. The surgeon did some stuff over 6 or 9 months, and at one point, redid diagnostics and quote, nothing wrong with the knee, and recommended euthanasia of the dog because he was so vicious. I mean, this big dog needed to wear a basket muzzle. No one could touch him except for the owners. They had to put him in a room in the house when people came over. He really had turned into a vicious dog. Somehow they sought me out, and it's like, yeah, bring him down. And they were highly motivated owners. And when they came in, and my receptionist said, okay, fill out the paperwork, and we'll put you in some exam room. And they're like, oh no, we cannot bring him in here. He will get very stressed, and he has his muzzle on, but he will try to bite everybody. And so I really did one of these parking lot exams where I couldn't even touch him. I just watched him walk, and it's like, well, he's still limping on his TPLO knee, so perhaps he's painful even though there's, quote, nothing wrong with the knee. And there was nothing wrong with the knee, but we treated him for this wind-up phenomenon, and NSAID and Nmda receptor antagonist and some oral opioid. And at 30 days, I do all my rechecks in 30 days. At 30 days, the owners are willing to bring him in. They left the muzzle on him, but I'm examining him, and he is nuzzling me. Very friendly. At 60 days, they had no qualms about him interacting with people anymore. So, if you didn't know exactly what his background was, you would just think he's just a vicious dog. But we were able to treat him for his allodynia, and really there was nothing wrong with his knee. It was all related to his spinal cord. And so, very important thing to be looking for. That's not to say there aren't some bad behaviors out there that are just mean dogs. And when everything I say about dogs is really true for cats and probably everybody else we treat, unless I separate that out. So back to this concept of a dog with a fractured femur versus a dog with bilateral hip arthritis. Both some form of a noxious stimulus. Just turns out that a fractured femur is a much greater stimulus, and it can actually turn on these Nmda receptors in maybe 15 or 30 minutes. So a patient who comes to you with a fractured femur may have maladaptive pain before they even get into your hands. Whereas osteoarthritis, if they're going to develop it, usually takes months to years, and certainly not every osteoarthritis dog develops that. So the big question is then, what turns on these Nmda receptors that causes maladaptive pain? As predominantly orthopedic issues, major trauma, forelimb amputations, and potentially spinal cord issues. Right? So soft tissue surgeries, they may be really painful, but they're not the right type of stimulus to actually turn on the receptor. So a perfect example of that, bilateral radical mastectomies in women, highly stimulating, painful, but they don't turn on Nmda receptors. So it's not like every procedure has the potential to do this. And so, our abdominal procedures and virtually all of our soft tissue procedures do not turn on Nmda receptors. All right. So pain elicits a neurohumoral response. We call it the stress response. The stress response is made up of increased circulating catecholamines like epinephrine and norepinephrine, increased ACTH and cortisol. We crank up the renin-aldosterone-angiotensin II system, increases in antidiuretic hormone, and we couple that with decreases in insulin and testosterone. That's stress. So when you're stressed, this is what happens to your body. A certain amount of stress, critical for survival, but if it's intense or prolonged, it's a problem and affects every single organ system in the body. It can decrease immune function, can decrease GI motility, and for a while that may just be uncomfortable, but we know that if the GI motility is decreased too long, it can predispose to bacterial translocation from the lumen of the intestine to the bloodstream, resulting in sepsis or septicemia. Not so good. This stress response can result in retention of sodium and water. Once again, may be uncomfortable, but if your patient happens to be a 10-year-old Cavalier King Charles Spaniel with subclinical mitral regurgitation, and now she has this retention of sodium and water, that may be enough of a fluid overload to cause acute congestive heart failure and fulminant pulmonary edema. We've actually seen a couple of those come through our emergency clinic that were dental procedures, older dogs, subclinical mitral regurgitation, 10 to 12 hours post-op, so these dogs are at home, they start coughing, everything during anesthesia went fine, they recovered fine, and then they end up in our emergency clinic. Heart failure. So, yes? Okay, so how do we determine that between that and fluid overload? Really easy. If they had a fluid overload, they would have had a problem in recovery or soon thereafter. So that's how you know it's not a fluid problem. This is an ongoing retention of sodium and water problem, so it's getting worse and worse as time goes on. Because they're really getting more and more painful. Their blocks are wearing off, and if you look at the records, they had woefully inadequate post-operative. Certainly decreases in oxygenation and ventilation, never good for a patient. And if you just put it all together, if you just think about surgery that we do, if patients are allowed to be painful and they develop a stress response, they develop a general catabolic and lipolytic state such that they don't heal well. If this is an osteoarthritis patient, that general catabolism and lipolysis really results in accelerated muscle atrophy. So they don't just develop muscle atrophy because they're not putting their legs through full range of motion. It gets worsened if they're allowed to be painful at the same time. So I want to show you an interesting study, and this is not a study about pain control versus no pain control. This is a study about post-operative intermittent pain control versus continuous pain control. And so this is two groups of young patients who are having thoracic surgery, and the intermittent group got an opioid as needed, if someone determined they needed it, and the continuous one got continuous fentanyl infusion. And if we just look at kind of the simple post-operative data, the patients who are allowed to be intermittently painful had almost 2 times on a percentage basis of developing low blood pressure. The patients who were allowed to be intermittently painful had almost 2.5 times the incidence of abnormal cardiac rhythms, and those who were allowed to be intermittently painful had a significantly more likelihood of developing sepsis, DIC, or dying. Right? So people who are used to looking at data will say, oh, you know, there's not equal numbers in these groups, and there absolutely are not, because the Institutional Review Board put a halt to this study as soon as really they recognized that 4 patients had died. And the unfortunate part of this study is that this was done in young children. And this was done while I was, during the time that I was a resident. And really the standard of care for young children was that they didn't feel pain, or at least it made no difference to them. Okay? So I can tell you part of my residency was at Children's Hospital in Columbus, Ohio, and kids who needed, like 7 or 10-day-old kids who needed thoracic surgery to close a PDA, I can tell you that they would be paralyzed and ventilated so that they could have a thoracotomy, but there would be no anesthesia at the time. But that was the standard of care. So this was really a landmark study for kids that showed, yes, pain and the stress response really is an important determining factor in kids as it is in adults. What we know now, like we know a lot more now, but there was a great landmark study that even looked at kids in the neonatal intensive care unit with heel pricks, because you know they get heel pricks for little blood sampling, and a group followed a whole bunch of those kids and their non-hospitalized cohorts up through their teenage years. So long study, like an 18-year study. As these kids became teenagers, a very significant proportion of them really got labeled as being wimps, that they really had much lower tolerance to a normal stimulus, like they hurt more easily, and they were considered wimpy compared to their cohorts. Well, now we understand that the right stimulus, repetitive stimulus over and over again, turning on their Nmda receptors, and there's some other mechanisms that can occur, but still they develop maladaptive pain. So the bottom line is, pain and the stress response can really take relatively healthy patients, make them sick, and even kill some reasonably healthy patients. So, you know, in our world, what that means is when you have really sick patients, make sure you are giving them good pain control. And remember, when they're really sick, they can't even show you that they're painful. So we have to make some assumptions about that. Otherwise, the lack of pain control, they really just kick them over the edge of the cliff and induce them to die. So the bottom line is, we treat pain not because we're nice people, but we treat pain because pain control is good medicine. So what about this concept of preemptive analgesia? The concept is preventative pain control, that we provide pain control prior to inflicting a noxious stimulus. Now, that's not always possible because, you know, patients get hit by a car, they get in dog fights, cat fights, whatever happens. But in that case, then it's our job to provide pain control before we inflict the next noxious stimulus, unlike what they oftentimes do to us if we end up in the ER, you know? Oh, you've got a broken radius ulna, let's just straighten that out, right? They don't always give you pain control. But the idea here is if we can provide early pain control, then it's going to make later pain control easier to achieve because we're going to help prevent this wind-up phenomenon. And then the final principle of providing multimodal or multi-factorial approach to pain control isn't just about drugs. It could be drugs, non-drugs, other interventions, good nursing care, you know, cold therapy, warm therapy. The idea is we're going to do things that have different mechanisms of action so we can get overall better pain control. And if we just kind of overlay that concept from a drug perspective onto kind of the pain pathway, we can affect that pain pathway very peripherally at this level called transduction. Transduction is the conversion of a physical insult into a biological signal. So I have another slide that has like a scalpel right here. So you know, you cut open the skin, that's a physical insult, but it has to really be converted into a biological electrical signal. So we can interfere with that very peripherally with both NSAIDs and local anesthetics. Then as that signal travels through the peripheral nervous system, is transmitted towards the spinal cord, local blocks can really stop that, protecting the dorsal horn and spinal cord. Once it gets at the level of the spinal cord, we can interfere again with opioids, alpha-2 agonists, at least for short term, Nmda antagonists, and epidural or spinal local anesthetics, regional blocks. Then, as that signal gets projected up to the higher centers of the brain, once again we can interfere with the perception of pain with gas anesthetics. That's why they work so well for us, because they stop the perception of pain. Patients stay still, we can get the job done, but you know, they're not so good after you wake up the patient. Opioids, which are critical for interfering with perception of pain. Alpha-2 agonists, which are good at interfering with perception of pain. And certain NSAIDs, at least, that work really centrally rather than just peripherally. So, now we're going to talk about drugs. We're going to talk a little bit about non-steroidal anti-inflammatory drugs, because even though I want to talk a lot about opioids, I don't like to leave out the concept about how important NSAIDs are. And you're going to hear me say this multiple times. NSAIDs are not a substitute for an opioid. An opioid is not a substitute for an NSAID. So, you know, we use NSAIDs a lot perioperatively, there are different approaches to whether we give them post-operatively or pre-operatively. And so usually it's a no-brainer to give post-operatively. But I'm an advocate of pre-operative NSAIDs, with the idea being we can hopefully attenuate the inflammatory cascade before it gets in full force, before we wait until the end of the procedure. And we have NSAIDs which are approved for use for pre-operative considerations, so we should really take advantage of that concept in appropriate patients. So, you know, the preoperative considerations are, if this procedure is going to probably be more than 15 or 20 minutes or something, they should probably be receiving IV fluids. More importantly, we should be measuring their blood pressure and treating it if it's low. And we should probably avoid preoperative NSAIDs if there's a likelihood of bleeding or it's something really out of the ordinary. And so really, we want to reserve preoperative NSAIDs for these ASA 1 and 2 patients. The ASA 1 patients are the normal healthy patients. ASA 2 patients are the patients with mild systemic disease, patients that you would have no problem probably giving an NSAID to anyway. And then the stable ASA 3 patients are those with moderate systemic disease, but they're stable, and they don't really have any contraindication preoperatively to an NSAID. But we're not going to give it to like crazy procedures. Like we're not going to give it to a dog who's doing well, and we're going to go take out a pulmonary mass. Like probably wait post-operatively, make sure they're not bleeding. So it's like just think about what the procedure is. If you're not likely to bleed, not likely to have complications, which is most of what we do, then preoperative NSAIDs are a reasonable concept. So we have a number of preoperative NSAIDs we can be using, and we'll talk about dogs, and then we'll talk about cats a little bit. But we have really a number of NSAIDs, and we have a couple of toxic class NSAIDs. And I just want to talk about the toxic class NSAIDs because I want to compare a dog to a cat here. So, the reason our NSAIDs work currently is based on conversion of arachidonic acid to some version of prostaglandins that have some effect. So we want to preserve cyclooxygenase 1, which produces good prostaglandins because they convey GI mucosal protection, they preserve renal blood flow, help the platelets stick together when they're supposed to stick together. The toxic class NSAIDs, intense COX-2 inhibitors, so they have an anti-inflammatory and pain-relieving effect. But we do know, especially from the human experience, if patients have a low blood flow state, which would be a contraindication to NSAIDs anyway, if they're dehydrated, hypovolemic, or shocky, like we shouldn't give patients an NSAID because cyclooxygenase 2 helps maintain renal blood flow. It's not just an inflammatory thing. It helps maintain renal blood flow. If patients get an NSAID when they're shocky or they have this low blood flow state, they're going to be at risk of acute renal failure. So when Novartis was bringing Onsior to the United States for cats, I have to be quite honest, my first gut reaction was like, this is crazy. Toxic class NSAID in a species which is persistently dehydrated. And I thought, we are just fraught. We're going to be fraught with renal problems. Well, normally my predictions on pain-relieving drugs are pretty accurate. However, I was inaccurate on this one because I didn't really understand the drug. Okay? So we have this intense COX-2 inhibition. As it turns out, the half-life of Onsior, whether injectable or oral, is really very short in a cat. Like, if you look at injectable to oral, it's like somewhere around 2 hours or so, okay? So the half-life is 2 hours, and I'm going to say like 1.5 to 3 hours, okay? So the half-life is very short, yet we get a 24-hour duration of action, okay? So if you just thought about elimination of the bulk of the drug from the body, like you would think, wow, we shouldn't really have effects for more than maybe 9 or 12 hours. But it does last for 24 hours, and that's because the half-life is really only part of the story. And it shouldn't surprise us because we know all the other NSAIDs that we're looking at, the pharmacokinetics do not parallel the pharmacodynamics, or what's actually going on in the body. So the reason that Onsior is really special for us for cats, that short half-life means the bulk of the drug's getting cleared quickly, but the Onsior is actually harboring in areas of inflammation. And so probably the reason why we don't have renal problems in cats, like we would have predicted, is the plasma levels don't stay elevated for very long, so the kidneys aren't getting hit very much. But if we're doing something that's inducing inflammation, that area of inflammation is holding on to the Onsior, so we get this anti-inflammatory pain relieving effect. So Onsior, like just injectable Onsior, just came on the market, and so this is. How many of you use oral Onsior in your cats? Okay, quite a few. Okay, but quite a few who didn't raise your hands. So if in fact you're being honest, which would be great, and you're not using Onsior in your cats, this is my plea to treat the poor orphan species appropriately. Like cats have gotten the shaft like for the duration that we've been treating them. We finally have an approved oral NSAID, which is approved for pre-operative use and then for a couple days post-operatively. Now we have the injectable to go with it, and I thought I was going to have it in my hands for last week's anesthesia boot camp where I train a lot of people and we do live animal training, but apparently shipping of the first bottles got delayed by a week or so, so it's probably going to arrive tomorrow at my clinic. But the concept is, I would much rather give an injection pre-operatively than an oral drug, especially when you want to dose this about an hour before surgery, because I usually give these cats their oral Onsior before I sedate them. My experience has been really interesting. If I give it to them after they're sedated, I have a bunch of cats that 45 minutes later, when I go to intubate them, they still have their tablet in their mouth, hiding under their tongue. So sedated cats are really good at faking that they're even swallowing. Okay, so they're outsmarting me on a regular basis. So I love the idea of an injectable version. I don't have to worry about it, and then they can go home with a couple days of oral Onsior. And unlike Metacam, which is approved for one dose post-operatively, 24 hours isn't enough time for an anti-inflammatory post-operatively. If any of you have ever had like some surgical procedure, and either yourself or you've had a loved one, someone close to you, you need to take some NSAIDs for a couple days for some pain control. So we finally have an injectable and oral version for cats. I implore you to use it in appropriate cats. Just like we wouldn't use a pre-operative NSAID in an inappropriate dog, use it in the appropriate cats. Like I probably wouldn't use it in an 18-year-old cat, even if it had normal kidneys, only because it's probably one nephron away from getting a So use it in appropriate cats. But most of the cats that we anesthetize are appropriate to receive pre-operative NSAID. So we have something that we can use in the poor orphan species. Ignore the picture. Like I put this slide together a while back. So this is an Onsior bottle from Europe that actually has a dog on the label, but ours will not have a dog on the label. Maybe in the future, but not right now. It's strictly approved for cats right now in the United States. Okay. All right, so avoid these type of NSAIDs perioperatively. I still run into people who are using ketoprofen, which amazes me because it's completely off-label. And now that we've had an approved NSAID in dogs and cats for years, you are at great risk if you use a drug off-label for the reasons that we have an approved drug. You have zero defense if something goes wrong. So we will talk about that more as we go. Any questions so far? Yes, sir.
Yeah, if you're giving it an hour before your surgery, you haven't really created most of the information that you're going to be creating. It's not as much anymore by the time you create that information. Are you kind of involved?
That's a great question. The question is, really, to paraphrase it, if we give an hour before surgery, is there going to be enough of it to have an anti-inflammatory effect because it has a rapid clearance? And that's why, like, an hour before is a good number, because the half-life is, like, if you look at different data, like 1.7 or 1.5 to 3 hours. So you definitely have a number of hours to induce your inflammation, and it still works, okay? But unlike if I give like a pre-operative NSAID to a dog, like we don't know if this is the true story for any NSAID in a dog, but presumably not. Like if I have dogs who are lined up for surgery, I give them all their NSAID at 7:30 in the morning. Can't do that with Onsior and a cat, because for it to really work, like in some reasonable amount of time, we should have some inflammation. Now, that being said, I qualified all this by saying the pharmacokinetics do not follow clinical effect in any of the NSAIDs. So maybe that's not real. Maybe that what we determine is the clearance isn't really accurate in terms of seeing an effect. But we should probably give the Onsior about an hour before, And I would say, even if you said you're giving it an hour before and things get delayed and you do surgery in 3 hours, you should still be okay, because it's going to take a number of half-lives before it's really cleared. So I can guarantee you in trials that nothing is ever perfect like an hour. Question over here.
Same question. If you don't have inflammation, how's it?
Yeah, if you don't have inflammation, eventually, then it's really not going to do much, right? And there's nothing for it to do. Other questions before we go on? Right. I'm going to change sides of the room. Right. Usually I just walk around, that's how I'm shaped. Okay, so let's talk about some opioids, right? We have a bunch of opioids that we can discuss. We're not going to talk about all of them. We're going to talk about the most commonly used ones. And to talk about opioids, we need to give some background information so we can understand them more effectively. So, when we talk about opioids, morphine is always our prototype because it was the first one, 1896 or something like that. And it's a pure mu agonist. We're going to compare some other drugs that are not mu agonists. But it's important to recognize that opioids, which have a full effect at the mu receptor, are the best analgesics on the planet currently, inflammation and neuropathic pain aside. They're not great for inflammation, they're not great for neuropathic pain. And we're going to talk about this concept of potency because I think it's important for people to understand things, not just use them. So the concept of potency of an opioid really refers to the dose relative to morphine to get an equivalent effect. And so if morphine has a dose of 1, or a potency of 1, this is very convenient when we talk about dogs, because the dose of morphine in a dog is about 1 milligram per kilogram. So how many of you use morphine in dogs? Right? Anybody use morphine in cats? Okay, so you'll probably won't after today. I promise to rock your boat somewhere during the talk. How many of you use hydromorphone in dogs? Okay, cats? I'm not going to tell you not to do that. Okay? So whenever I tell you not to do something, I will always give you an alternative. So hydromorphone is 5 times more potent than morphine, which means we use 1/5 of the morphine dose to get an equivalent effect. So if the dose of morphine is 1 milligram per kilogram, the dose of hydromorphone is 0.2 milligrams per kilogram. And that would be like a sub-pure IM dose. So most of you probably use 0.1 milligram per kilogram. Doesn't mean that that's the wrong dose, it just means that it's not the equivalent dose. So, if you want more pain control, increase the dose. Injectable fentanyl. How many of you guys use injectable fentanyl? Right? So, yeah, a little more limited use. It's 100 times more potent than morphine. If we were going to actually use it as a pre-med, which we did for a while many years ago when oxymorphone went away and we didn't know to use hydromorphone, But the dose of fentanyl then would be 0.01 milligrams per kilogram to have an equivalent analgesic effect as morphine. Anybody here ever heard of remifentanil? Right, so remifentanil, interesting drug. It's really an ICU emergency drug because it requires no liver metabolism or renal excretion for its duration of action. Its duration of action with intravenously is 8 to 10 minutes. And that is totally consistent because the duration of action is due to general esterase degradation, and the general esterases are abundant in the plasma and skeletal muscle, and we never run out of them. So whether we give a patient a single IV dose to last for 8 or 10 minutes, or we put them on a continuous infusion for 6 hours, when we turn it off, it's gone in 8 to 10 minutes. So the question is, why would we ever use it? And in part, and I don't think this showed up in my introduction, but I do own 2 emergency practices, so I have strong interest in emergency medicine and everything that goes with that. We use it in our intensive care unit, especially when we have trauma patients who need analgesia, but they may also have neurologic sequela from their trauma, maybe head trauma, something, so we can keep them really comfortable. And when it comes time to do another neurologic exam, I can turn this stuff off, and in 10 minutes I know when I do my neuro exam, if it is abnormal, it's not the opioid, period. Whereas if I have them on fentanyl or any other opioid, I can turn it off in some amount of time, but we never really know when it's gone because there's always variable metabolism. So when I have a patient on fentanyl, I turn it off, and 30 minutes later I want to do my neuro exam and it's abnormal, my question always is it the opioid or is it the neurologic process or abnormal neurologic process? So remifentanil is a very cool drug for IV use only, and you can use it in dogs and cats. So we predominantly use opioids because they induce analgesia, and oftentimes as a pre-med because they induce sedation. So those are some of the good things, right? But, you know, no opioid is perfect, and so we have the potential for dysphoria, which is always annoying. I don't know if it really hurts the patient, but it is annoying. And then we have to give them a tranquilizer like acepromazine or trazodone, or tranquilizer sedative like dexdomitor to really mask or get rid of that dysphoria. Or sometimes we do a partial reversal with naloxone or nalbuphine or something. And that partial reversal, there's always the potential for behavioral changes, but it should be a very, very small percentage. I don't remember the FDA clinical data, but dysphoria was really, really low. 500 cats or whatever that went to study. Yes? Right, so the question is that our pre-op, and so yes, we're using this as our pre-operative opioid that carries us intraoperatively to the post-operative phase. And so when we use it, like we're either giving them a big dose of acepromazine, 0.1 milligrams per kilogram, to help calm them, or we're combining it with dexdomitor so we get good sedation. Okay, so we use that pre-op, and then it carries us for 24 hours.
So you use it with a dex, the Nmda, and then the NSAID.
Right. So the protocol would be, my typical protocol would be they would get a low dose of dexmedetomidine, like 10 micrograms per kilogram, mixed with the Nmda as a pre-med, and depending on what the timing is, you know, we would normally have given them oral Onsior, but now we're going to give them, my practice will give them injectable Onsior and send oral Onsior home. Other questions? What's that? My dexdomitor dose for cats, for most cats, is like 0.01 milligrams per kilogram, 10 micrograms per kilogram. So much lower than the bottle dose. And you can definitely use much lower doses when you combine it with an opioid, both in dogs and cats, because even though they're working on different receptors, Opioids are working on opioid receptors, dextromethorphan alpha-2 receptors. At the molecular level, they're going through the same signaling protein. It's called the G protein. So they both go through the same signaling system on them. And so you actually get a synergistic effect. So you take doses where things are kind of mild sedatives all by themselves, you get significant sedation putting them together. Okay, and so then the question is, what are we using for induction? You'll see we predominantly use alfaxalone now, alfaxan, new induction agent. If I'm someplace, I do anesthesia at a couple different places. We don't have that. We're usually using propofol. So you can use anything that you use. I'm not ignoring you.
Just to clarify, is the 0.24 mg per kg, is that just for Cymidol, or that's for
Okay, so this is a good question. So is the 0.24 milligrams per kilogram just for Cymidol? All right, so the way I will answer that is Cymidol, what makes Cymidol different is it's more concentrated. It's 1.8 milligrams per ml instead of 0.3 milligrams per ml. You could likely get the same effect with your regular buprenorphine, however it will cost you more. So Cymidol actually costs less at this dose than regular buprenorphine. But it's not a sustained release or anything like that. Okay? It's really just a concentrated, high-dose, long-acting buprenorphine. In the back, sir. Or ma'am.
Can you use Cymidol transmucosally for the
Can we use Cymidol transmucosally? I used to say we didn't know the answer to that, but I just saw some data, totally off label, but at least in a study that was looking at regular buprenorphine versus high concentration buprenorphine, the Cymidol lasted 6 to 12 hours, and the regular buprenorphine at 0.01 to 0.03 milligrams per kilogram lasted 2 to 3 hours. So the current data is that what we've been doing still doesn't work very well. And so transmucosal Cymidol will work better. It's not its primary purpose, but it does work. We send it home with owners in a syringe with 25 gauge needles so that they can get a sub-Q.
I'm sorry, I can't hear all the way back here.
Okay, so we send it home with owners.
For sub-Q?
We send it home with owners to give sub-Q. Exactly. Just like, owners give sub-Q fluids, Adeclon, all kinds of stuff.
But what you just said was it will work transmucosally,
there's one study that shows transmucosally at that dose lasts 6 to 12 hours. And probably because it's a big enough volume that it doesn't all get absorbed transmucosally and they swallow some of it. And if they swallow it, then all bets are off because it requires much higher dose. You have questions, sir?
Did you say this is labeled for 3 days of consecutive use?
Yes, this is labeled for 3 days of consecutive use. For some, we do a lot of things off label. So some things we do in cats, we use it for 5 days off label. Yes?
Any comments on the long-acting?
Buprenorphine SR?
Yeah.
Okay, so I don't think I put my buprenorphine SR slide in. No, okay. So buprenorphine SR, which is made by Zoofarm in Fort Collins, Colorado, I highly discourage you from using it for a couple reasons. One, the data on which it is based is really weak. 12 cats, and really if you read the study, you could see that they can't really tell the difference between a painful cat and a non-painful cat. So the data is very weak. Like if we could get a drug approved based on 12 cats, like wow, our drugs would be like infinitely cheaper. Like it wouldn't cost millions of dollars to get a drug approved. So that's the most important reason. Two, I think it's unethical that they actually market it to veterinarians because it's not an approved drug. Three, you really put yourself at risk if you're using that drug because we only have the privilege of using drugs off label if there isn't a drug approved for that use. Now we have Cymidol, which is approved for 3 days of analgesia. If you use buprenorphine SR and you have a client who recognizes, wow, either the pain control isn't very good, or there's an adverse event, and they either go to the state board or decide to sue you, you will have zero defense. There will be, the court would not listen to anybody who says that it works, because it is being used off-label. So there's a significant medical legal issue. Okay, so we've kind of got cats taken care of now when we think about how do we keep them comfortable as we send them home, right? Because the challenge of sending patients home is really having a drug that works, has an adequate duration of action, such that we don't have to worry about client compliance. So, you know, NSAIDs we can manage once a day. Anybody familiar with the Hills American Animal Hospital client compliance study from 2003? Yeah, you know, most of you are much younger than me. It was a really interesting study because it was to look at client compliance, and really what the data showed was that people treat their animals as well or not as well as they treat themselves. And what that means is if you ask somebody to do something once a day, they're pretty good at it, okay? If you ask somebody to do something twice a day, they're really not that good at it. And if you ask them to do something 3 or more times a day, client compliance really becomes pretty abysmal. So the less we have to depend on a client to keep their pets comfortable, the better off our pets are, right? So cats we kind of have under control because we give them Ensure once a day, which owners are pretty good at, and they can give, or we can give, Nmda once a day. So we've got cats covered. But what about dogs? You know, how many have used Tramadol on dogs? Okay, hopefully after today you don't. Hi, oh my gosh. Hey, so here's the issue, is when Tramadol came out, we all thought, oh, non-controlled drug, an opioid-like drug, has something like mu agonist effects, sounds great. The problem is, Tramadol needs to be converted into an active metabolite for it to work. And it needs to be converted into O-desmethyltramadol. And dogs don't make it. Okay? In fact, we now know that a lot of humans don't make it. So people like me who have taken Tramadol get zero beneficial effect. They used to just call us non-responders. The reason we're non-responders is because we don't make the active metabolite. So likely not very efficacious, but that's not just me, that's really the data. If you try to find good data for Tramadol in dogs, you're going to find good data for injectable Tramadol in dogs, not oral Tramadol in dogs. And yet we have a plethora of data which either shows that dogs don't make the Tramadol or that analgesia is not good. And I'll show you some of that. And I used to say, I extrapolated this slide into my new slide. I used to say it was best when given with an NSAID. And of course it was best when given with an NSAID because an NSAID was doing something, right? So we think we can get O-desmethyltramadol if we give dogs 6 to 10 milligrams per kilogram orally 4 times a day. And probably most of you are using like 2 to 3 milligrams per kilogram 2 to 3 times a day. So at that dose, dogs don't make O-desmethyltramadol. At this dose, anybody ever given this dose to a dog? They usually make them pretty sleepy, right? Yep. Okay. If you give it long enough, they will accommodate to their sedation, and they probably won't be sleepy. But we have interesting data. So, oh, and I forgot to tell everybody, if you want copies of the updated version of these notes, I have some handouts over here on over by whatever table that is. And I have some handouts that have my address on them and some magnets, and if you run out, I have more, so you know how to get them. But this is just 7 of the papers that are out there in the literature that show either dogs don't make the active metabolite or it doesn't produce analgesia. But I love this, I don't know if this has actually been published yet, but it was presented as an abstract that the Veterinary Orthopedic Society made a couple years ago. And this was an interesting study because it was experimentally induced knee arthritis and then force plate analysis after tramadol. Okay, and these dogs were getting, I think, 6 milligrams per kilogram, 4 times a day of tramadol, trying to make the active metabolite, and they were allowed to acclimate to it. So they got to the point where they were not sedated. Right? So what's interesting about this is force plate analysis, which is our gold standard. Dogs who got tramadol had 0% improvement in their weight bearing. Okay? Now, I like to talk about this because 0% is really an important number. It really is. Because if we do a placebo-controlled pain study in dogs or humans or cats, the typical placebo effect is 30 to 40%. So really, tramadol is worse than a placebo. We would be better off spitting on the dog rather than giving them tramadol. So really, you know, so yeah. When I really put all this information together, and then tramadol became a controlled drug, I had a meeting with my management team, and I said, it was like Thursday, and I said, let's say, like, you know, we have like these bottles of like 1,000 tramadol, we have like 5,000 tramadol on the shelf, and I said, okay, so after we run out of tramadol, we're going to do something different. So that was Thursday. Friday, I'm in the shower in the morning, and I think to myself, that was a crazy thing I told them. It's like, how can I ethically be giving tramadol to dogs, have my doctors prescribing tramadol to dogs, when I know it doesn't work? Or maybe there are some dogs that make some ODES methyltramadol, but in general, like, it's not going to work. And so, like, I sent an email out to everybody because I wasn't in clinic that day, and I said effective Monday, because it's going to take that long for everybody to see the information going through the emergency plans. Effective Monday, we're not doing any more tramadol, and whatever we have to do to reverse distribution or whatever we have to do with it, we're going to do it. So we use no tramadol in our practice. All right. So what are some options? Well, you could use codeine. I mean, codeine's a pretty good analgesic. 1 to 2 milligrams per kilogram, 2 to 4 times a day. It does have a ceiling effect, so it's not great for severe pain, but for mild to moderate pain, it's pretty good. And it's pretty likely to induce sedation or dysphoria. How many of you use fentanyl patches? Okay. Can we turn on the lights a little bit? Someone? Anybody know how to do that? Oh, perfect. Okay. So fentanyl patch is interesting. You know, they're not approved for use in dogs, and the data is really variable. You know, experimental data, really good translocation of the fentanyl from the patch through the skin and reasonable plasma levels. So the concept of transdermal fentanyl is really good. But patches don't stay adhered to the skin very well. You know, and we did a study back when I was head of anesthesia at Colorado State. We kept clinical cases in the hospital with jugular catheters in so we could get blood samples easily out of these dogs. And 84% of those dogs had one or more time periods over 72 hours where they had subtherapeutic plasma levels of fentanyl. And once they have one time period, the rest of them are always subtherapeutic. And so if we spin that around, it means that overall, we could depend on 16% efficacy for 72 hours on the infiltration. Now, if you told an owner, like, here, I don't even know what fentanyl patch costs now, but here's an $80 or $100 patch, and there's 16% chance it's going to keep your dog comfortable for 72 hours. Like, the owner's going to probably say, like, can you do something better? And of course, the answer is yes, we can do something better. So, and you'll see now there's always been a medical legal issue with fentanyl patches because of human abuse potential. Now there's even more of a potential. How many of you have heard of Recover, a transdermal fentanyl solution? How many of you have not heard of it? Okay. Great. So this is transdermal fentanyl. Remember I said the concept of transdermal fentanyl, really good concept, The patch is the wrong implementation. So this is fentanyl that you drop in one of these syringes, and you part the fur and you squirt it on the skin. This is the applicator tip right there. And at the bottle dose, at the label dose, it's labeled for 4 days of pain control, and it's made, the label is to be given pre-operatively for intraoperative and post-operative pain control that lasts for 4 days. So this is a whole different concept. And so when we use this, regular fentanyl is 50 micrograms per ml, and transdermal fentanyl solution, Recovera, is 50 milligrams per ml. So it's 1,000 times more concentrated. So there are some potential, I think, very unreal human exposure concerns that I'd just like to talk about. Because if you want to get this drug in your practice, the FDA or the DEA or whoever requires that you do this risk minimization action plan training. And this is really like a 15-minute training thing, which is really the label, the insert, the package insert on a website they have to go through. So the DEA license holder and one other person in practice need to do this. I have all my staff do it, but I like to put it in perspective because there's a good chance that if you just took this at face value, like it would scare you, okay? Has anybody done that, taken it and it's like, oh, no way, right? So I like to put it in real clinical perspective. So, you know, you squirt you don't clip the fur, you put between their shoulder blades, and when you put it on a dog, it's 100% dry in 5 minutes. And it gets absorbed through dog skin really well. If you were to take the bottle up, cup your hand and pour the bottle in your hand, what time is it? It's 4 o'clock. If you were to put it in your hand now, if you're going to bed at midnight tonight, you still will have no therapeutic plasma levels of fentanyl 8 hours later. In fact, it takes like 18 to 24 hours in a human to have adequate plasma levels. So there's a recommendation that you wear gloves and long sleeves and eye protection when you're administering it. If you forget to use the glove and sleeve part, and you get it on your skin, like you're going to do the same thing like if you get morphine on your skin, or Valium or amoxicillin. You know, you're going to go and you're going to wash your hands. And if you forget to for the next 20 minutes, or really for the next 15 hours, you're still not going to need drug. Okay? And I have more to talk about, but I will answer that question. Great question. So if we're putting it between your shoulder blades and then we lay them on their back on some heating source to help keep them warm, does it affect the absorption? The answer is absolutely not. So very different than a patch, the kinetics of a patch. The heat has no effect on the speed at which this is going to take effect. So back to this human exposure thing. So while it doesn't absorb through skin very well, it will absorb through mucous membranes. Okay, so you know it is a recommendation, and this, I would say this is very important. If you wear glasses, wear your glasses, and if not, you should wear some protective eyewear. In my clinic, we got everybody. I'm a woodworker. We got everybody these like Oakley style woodworking glasses, just clear glasses. Like there's no way I was going to get them like chemistry goggles. Like, no way. But actually, they think the Oakley glasses, Oakley style glasses, are very cool. People just wear them around, and in fact, they disappear all the time. People are taking them home, right? And they don't bring them back. So we're kind of like but they're only like $3.95 a piece. So, but if you were to get it in your eye, like it is worthy probably of a 911 call. So wear your glasses. As a medic, I give fentanyl and or intranasal fentanyl to humans regularly, and this is a significant dose if you would get it in your eye. I don't think it would kill anybody, but it would probably make you sick. So it is worth that. Put that in perspective, all my years as an anesthesiologist giving drugs sub-Q IM to patients, certainly I've had syringes pop off needles. I've never gotten splashed in the face. In all my years of giving topical parasiticides to my animals, I've never gotten splashed in the face. So I think the likelihood is really small. But if you were to get it in your eye, unlike your skin, it could be a real issue. There was, I'm going to come back, I'm going to answer a couple questions in a second. There was this study about what happens if you pet the dog. Okay, so they gave recovery to dogs, and like at 24 and 72 hours, they had Australian human volunteers pet the site, like really rub the site for 30 seconds with all 5 fingers on one hand, and then suck each finger sequentially for 15 seconds. So 75 seconds of finger sucking. Right? Like, I don't know who you get to do this, but I'm sure they were paid. They called them volunteers, so in theory they weren't paid, right? But then they drew blood to look at plasma levels of fentanyl. And about 50% of those people had no detectable fentanyl. 50% of those people had a fifth to a tenth of the therapeutic dose. So they didn't get drugged, but they had some low level of fentanyl. But there was this extrapolation by the FDA that if that was a child, like maybe it would be an issue. No, this is petting the dry area because there is residue. Okay, so there's this recommendation that small children be kept away from these dogs for 72 hours after administration. And some people have gotten uptight about that. For me, that didn't change anything that we have ever told owners. We have always told owners for dogs and cats that after they've had surgery, you should keep little kids away from them because their behavior may be abnormal, and we don't want them to get bit. So, it's the same thing. The reality is we know that owners don't do everything we tell them to do. And in a couple years it's been on the US market, and a couple more years longer than it's been on the European market, there have been no reports of kids getting exposed to it. So, I think it's like all these things are theoretical concepts that are not coming to fruition. Slides before, or questions before you go on this? I'm going to talk about cats. Hang tight. Okay. Anything else? Okay, let's keep moving. Yes.
Have you acted as an expert witness at a federal trial for some child dying for an unrelated cause in your description, but they're convinced that it was due to the drug, and then they raise a lawsuit? I mean, is it defensible, basically?
So the question is, like, if I was, I don't think I'd go to federal court. If it went to court, and I was for a child who died, probably unrelated to this, but could we defend it? I think it'd be a really easy defense if they never got a plasma fentanyl check in that child. Okay, so if the people were concerned, hopefully they told an ER doctor or even post-mortem, oh, my dog got this, and they can look for fentanyl. Okay, I think otherwise, I think you could really argue because there's nothing as a precedent to show that it would be an issue. And I think I could defend it really easily. Okay, so I showed you the applicator tip. This is just kind of a close-up picture, parting the fur, administering this to the skin. 95% of this is alcohol, so it evaporates, and so it's dry in 5 minutes. 100% dry in 100% of dogs in 5 minutes. And then there's a penetration enhancer that drives it into the skin, and then it slowly gets delivered into the bloodstream. So it's like having a continuous infusion of fentanyl, but it lasts for days. All right, so what do we use it for? We use it for things as simple as ovariohysterectomies, dental surgery, although it's not really, dental pain is kind of its own area, so it's not really approved for dental pain. But to me, it's a surgical procedure. Stable abdominal surgery, stable traumas, and trauma surgery, routine orthopedics, and once again, coming back to these ASA 1 and 2 dogs, we give it normal healthy dogs, dogs with mild systemic disease, and these are the stable dogs who have moderate systemic disease. So I have an emergency clinic, we use it off-label all the time on emergency. Dogs who come in with fractures, we give them half a dose of hydromorphone so they get analgesia now. We give them their Recovera, so as the hydromorphone is wearing off, the Recovera is wearing on. and now they've got 4+ days of pain. So, you know, they're not gonna have surgery tonight, and it's Sunday night, so they'll have surgery tomorrow morning with our orthopedic surgeons. But if it's Friday, they're probably not gonna have surgery till Monday, and they're still gonna be pain. So, you know, we just have to do what we can to stabilize that fracture until the surgeons get involved.
How long do you say it takes to
It takes 2 to 4 hours to take effect. So I usually count on 2 hours. But if you look at it, there's some variability. So this is the drug. Remember I said if I'm using an NSAID in a dog, pre-operatively, like all the dogs get their NSAID at 7:30 in the morning. If we're using Recovera, all my patients get their Recovera at 7:30 in the morning, because who needs to time it? Now, the only patients that we may have an issue with are the dogs who are going to have surgery at 8:30, and we only have an hour. And those are dogs just like the fractures on emergency, totally off-label, that we give them a half a dose of hydromorphone to bridge the gap. Because hydromorphone and fentanyl are going to have an additive effect because they're both working at the same receptor. And so we're gonna get significant analgesia quickly from the hydromorphone. The fentanyl levels are increasing as the hydromorphone wears off. The fentanyl levels should be So the nice thing about Recovera, this transdermal fentanyl solution, is it solved the problem that we came up to. Is what can we do to keep dogs comfortable as we send them home? At least reasonably healthy dogs. Because it's fentanyl, you know, it's not a new drug, it's just different delivery, so we know it works. It's got the duration of action, so we don't have to worry about client compliance, they just have to get their NSAID. We don't want to use this in cats, period. Whereas, you know, we're really good at going off-label. Dogs have good absorption, humans have poor absorption, cats have super absorption. And there's no known effective dose of Recovera without inducing dysphoria or mania in the cat. So just don't do it, period. Okay? All right, so what are some issues? Like, no drug's perfect, and then like the issues kind of get potentially amplified, or the concept of the issues get amplified, bless you, because of the duration of action. So what about sedation? If we look at the FDA clinical trials, 2.7% of dogs are sedate 24 hours later. Okay. Now, that should not be a surprise to us that there's a certain percentage of dogs who are sedate later, because if you just think about metabolism and a bell-shaped curve, like there's always a group of patients who have slower metabolism, like 3 or 4%. This is 2.7%. So we just don't notice it in most patients because if that happens to be oxymorphone, then it lasts a little bit longer, like no one cares. And if it's an antibiotic and it lasts longer, like nobody knows. So what do we do if a patient is sedate the next day with alcohol? Well, one, what I say is embrace it. Okay, so it's and it's reversible, but don't reverse it. One, if you reverse it, you have to keep reversing. Okay, but if you reverse it, then you get rid of all the pain control. So it all has to do with, like, if your patient's going home the next morning, it all has to do with how you talk to the owner. So up front, we tell an owner we may be using this long-acting pain reliever. It's going to last for 4 to 7 days, and it's great. You won't have to do anything except give the Duramax or Nmda or whatever you're going to give. But we say, like, there's a chance your dog will be drowsy. Like, I never use the term sedation with an owner because they have different connotations of that. But there's a chance your dog will be drowsy. If that happens, like, it's okay. Like, she will have just had surgery, and it's okay if she's drowsy. Like, we want her to rest. Like, dogs who, you know, have had their femur fracture repaired don't need to be bright and alert in a day. If they are, that's fine, but they don't need to be. So we have the right discussion with the owner up front. So if it occurs, we just say, oh, remember we talked about this, and it's okay, she's really comfortable. She'll still get up, go out and pee, come in, lay back down. All right. What about dysphoria? Okay, now in FDA clinical trials, there are no reports of dysphoria, which is kind of amazing, you know, it is an opioid. But people have reported dysphoria. I haven't seen dysphoria. I've been using this since August of 2013, I think. So yeah, a little more than 2 years. I haven't seen the dysphoria, but I don't doubt that it occurs. Because we certainly get dysphoria with IV fentanyl. So, you know, if they're in the hospital, you can manage them with acepromazine or trazodone, or send them home with trazodone. And it should just take care of the dysphoria, 5 milligrams per kilogram, a couple times a day. And, you know, it's not like you're going to have to manage dysphoria for the whole duration of the recovery, because you know, plasma levels of recovery are going to come down. So maybe after, you know, if they really have dysphoria, maybe after 12 or 24 hours. There appears to be about a 3 to 5% incidence of anorexia or loss of appetite. I usually don't worry about that unless it goes out like 3 days. Okay? And even then, I don't know if I have to worry about it. But, you know, all these, like, these are reasonably healthy animals that we're giving it to, so they should be able to manage it. If we've gotten concerned about it, we give them a dose of Cerenia on day 3. And I met a practitioner who now, even though this only occurs in like 3 to 5% of patients, I met a practitioner who just said, I don't want to deal with it. Right? So what he does is he sends home a Cerenia tablet with every patient and just said, like if he has surgery on Monday, he just says, on Wednesday give this. And then he never has to worry about it. So interestingly, it is an opioid, so it can induce hypothermia. So you don't want to forget like all your other management. They still get IV fluids. That if you use an NSAID, they still get an NSAID. You got to manage the cold. So what I say is manage the adverse effects. Avoid reversal so you can maintain the pain control. So you can manage adverse effects without fixing the underlying drug. Okay, and then you integrate it into your anesthesia. You do everything else you are going to do except for the opioids. So if you would normally give acepromazine, you're going to give acepromazine. If you're normally going to give an NSAID, you're still going to give an NSAID. It just all this did was take care of the opioid component long term. All right. So this is some version of my pack. So as we finish up and we go have drinks or whatever they have for us, remember pain control is not an optional concept for our patients. We have to advocate on behalf of those who cannot advocate for themselves. Both dogs and cats deserve an NSAID and an opioid for optimal perioperative pain control. And we have good approved drugs to get the job done. So, you know, if we have a drug which is labeled for its use, use it. Happy to answer any questions. Yes?
Your dose of methadone for cats, injectable and oral?
Okay, so methadone in cats, the sub-Q IM dose is 0.25 milligrams per kilogram. Now, it typically lasts about 3 to 4 hours. IV dose is much, much smaller. It's about 0.005 to 0.05 milligrams per kilogram. And the transmucosal dose is 0.1 milligram per kilogram, transmucosal a couple times a day. Okay, yes? Fentanyl patches in cats, the concept is the same. They work sometimes, they don't work sometimes because the patches don't stay adhered. We always know a fentanyl patch works when they get dysphoric and we have to pull it off. So the good thing is we have Nmda. So, you know, we've got cats covered. Yes?
Injectable Rimadyl versus oral.
Well, what's the question?
Well, there's difference between
About onset.
I give it as soon as I have space, and I would like to see it used more.
Okay, so the question has to do with injectable versus oral Rimadyl in dogs. So I would give it preoperatively, and if I were going to use Rimadyl, I would give pre-op Rimadyl, injectable Rimadyl, not oral, because injectable Rimadyl has a gas-sparing effect. Okay, so besides its anti-inflammatory effect. if you were going to give it like post-operatively, I would give it, I mean, I always give it pre-operatively, but I would give it when they're extubated, right? And of course, they're going to be much more amenable to an injectable drug when they're extubated than an oral drug. So yeah. There's this discussion about onset of action. The injectable Rimadyl has about a 45 to 60-minute onset of action, just like oral.
Question slightly off topic, but what are you currently doing for your older arthritic cats on a daily basis?
Say that again, something about arthritic cats.
Your older arthritic cats on a daily basis.
Okay, so this is totally off topic, and this is really a 2-hour talk. But the question is, what about older arthritic cats? Let me tell you first about younger arthritic cats. So younger arthritic cats being like 10-year-olds, okay, with no renal disease. The Elanco people should close their ears because we have data out of Europe for oral Onsior long-term use. And we have some data in the United States, it's just not approved. So younger cats, I use oral Onsior day after day after day. My approach to cats is a little different than dogs. I check them every 3 months. I just check their BUN and creatinine every 3 months. Right? As cats get older, so the question is the same thing as dogs. Like, what do you do for patients who can't take an NSAID but they have arthritis? So very quickly, there are a handful of things that work, okay, and we have data for. And right now, in cats and dogs, those patients that I use Dasequin Advanced. It's like Cosequin plus Dasequin plus a couple other things. Works really well. That's one thing. We could be using oral duralactin, which is a milk-based protein. Data in dogs that it works. Those are probably the 2 best things if we think about cat. Okay, so we have ways. Like patients who have arthritis always deserve an anti-inflammatory component. An opioid is not a substitute, and certainly tramadol is not a substitute in a dog. So they always deserve an anti-inflammatory component, even if we can't get past it. So that's part of that. Yes?
Your cocktail for the stable cat of low-dose Dexdorm and Cimbadol and Onsior, what would you then modify to go to the unstable older cat that you have to anesthetize?
Okay, so the question is, what about, like we talked about Dexdomitor, Cimbadol, and Onsior for kind of reasonably healthy cats. As they get sicker, the likelihood for an NSAID goes away, right? Until proven otherwise. So they may not get an NSAID, but all my dogs and cats who can't get an NSAID perioperatively get actually this homeopathic called injectable Tramadol. Data in humans for 24 to 72 hour anti-inflammatory effect. Some really good data in humans. Presumably it works in animals. And the reason I say that is the oral version Zeal has been shown to be equivalent to carprofen for osteoarthritis in dogs in a well-done published study. So that is my anti-inflammatory perioperatively if I cannot give an NSAID. Okay, so that part's covered then. Depending on what their problem is, they may or may not get Dexdomitor, right? If they have any renal disease, they're not going to get Dexdomitor. Depending on what their cardiac disease is, it may be indicated or contraindicated. But that's where Methadone comes in. If I can't use Cimbadol, I'll use Methadone. Got good analgesia, maximal analgesia, has some reasonable duration of action. We can use it as a continuous infusion, and we can send it home transmucosal.
So from a sedative quality, you don't bring in midazolam or
Oh yeah, so I may be, so I can't use Dexdomitor, so I may very well give midazolam and methadone to the cat for sedation, yes. So midazolam 0.1 milligram per kilogram, methadone 0.2 milligram per kilogram, combine in a syringe, give us it. Okay, I'm gonna stop. If you have questions, like come up, I gotta pack up. Otherwise, I'll mill around for drinks or whatever. Thank you very much.